Okay, today's next topic is hemorrhage. In that types of hemorrhage, there are three types. In first type, we have arterial, venous, and capillary. Arterial hemorrhage. Arterial hemorrhage is recognized as bright red blood spurting as a jet which rises and falls in time with the pulse. In protracted bleeding and when quantities of intravenous fluid other than blood are given, it can become watery in appearance. Venous hemorrhage. Venous hemorrhage is a darker red, a steady and copious flow. The color darkens still further from excessive oxygen desaturation when blood loss is severe or in respiratory depression or obstruction. Blood loss is particularly rapid when large veins are opened. For example, common femoral or jugular. Venous bleeding can be under increased pressure, as in asphyxia or from ruptured varicose veins. Capillary hemorrhage. Capillary hemorrhage is bright red, often rapid, and oozes out. If continuing for many hours, blood loss can become serious, as in hemophilia. Second type, we have primary, reactionary, and secondary. So, primary hemorrhage. Primary hemorrhage occurs at the time of injury or operation. Reactionary hemorrhage may follow primary hemorrhage within 24 hours, like usually 4 to 6 hours, and is mainly due to rolling of a ligature, dislodgement of a clot, or cessation of reflex vasospasm. Secondary hemorrhage. It occurs after 7 to 14 days and is due to infection and slogging of part of the wall of an artery. Predisposing factors are pressure of the drainage tube, a fragment of bone, a ligature in an infected area, or cancer. It is also a complication of arterial surgery and amputations. The third type, in that we have external and internal hemorrhage. External hemorrhage, this is visible and it is a revealed hemorrhage. Internal hemorrhage, this is invisible, concealed hemorrhage, and it is also called as concealed hemorrhage. Internal bleeding may be concealed, as in ruptured spleen or liver, fractured femur, ruptured ectopic gestation, or in cerebral hemorrhage. Concealed hemorrhage may become revealed, as in hematemesis or melena from a bleeding peptic ulcer, as in hematuria from a ruptured kidney, or via the vagina in accidental uterine hemorrhage of pregnancy. Next is classes of hemorrhage. There are 4 classes. I think you can just go through this. It's not that important. Next is methods of determining acute blood loss. Firstly, assessment and management of blood loss must be related to the pre-existing circulating blood volume, which can be derived from the patient's weight. For infants, it is 80 to 85 ml per kg. Adults, it is 65 to 75 ml per kg. So how do you measure the blood loss? So firstly, we have the blood clot. The size of a clenched fist is roughly equal to 500 ml. Swelling in closed fractures. Moderate swelling in closed fracture of the tibia equals 500 to 1500 ml of blood loss. Moderate swelling in a fractured shaft of femur equals 500 to 2000 ml blood loss. The swab weighing, it's not that important, but still you can just go through that. Next is hemoglobin level. This is estimated in grams per 100 ml, that is grams per deciliter. Normal values being 12 to 16 grams per 100 ml. There is no immediate change in hemorrhage, but after some hours the level falls by influx of interstitial fluid into the vascular compartment in order to restore the blood volume. Measurement of central venous pressure. Continuous tissue oxygen tension measurement. Next is managing the internal bleeding. ABCs, that is airway, breathing and circulation. High concentration oxygen. Assist ventilations. Control external bleeding. Stabilize fractures. RICE, that is resuscitation, investigations, clinical examination and evaluation. Transport rapidly to appropriate facility. Next comes control of external bleeding. Pressure dressing, that is use bandage to secure dressing in place. Tourniquets, final resort when all else fails. Used for amputations. 3 to 4 wide blood pressure cuffs. Write TK and time of application on forehead of patient. Notify other personnel. Once applied, do not remove it. Next is treatment of hemorrhagic shock. The primary treatment of hemorrhagic shock is to control the source of bleeding as soon as possible and to replace fluid. In controlled hemorrhagic shock, where the source of bleeding has been occluded, fluid replacement is aimed towards normalization of hemodynamic parameters. In uncontrolled hemorrhagic shock, in which the bleeding has temporarily stopped because of hypotension, vasoconstriction, and clot formation, fluid treatment is aimed at restoration of radial pulse or restoration of sensorium or obtaining a blood pressure of 80 millimeters of mercury by aliquots of 250 ml of lactated Linger's solution, that is hypotensive resuscitation. This is very important. Crystalloid is the first fluid of choice for resuscitation. Immediately administer 2 liters of isotonic sodium chloride solution or lactated Ringer's solution in response to shock from blood loss. Fluid administration should continue until the patient's hemodynamics becomes stabilized, because crystalloids quickly leak from the vascular space. So each liter of fluid expands the blood volume by 20 to 30%. Therefore, 3 liters of fluid need to be administered to raise the intravascular volume by 1 liter. Alternatively, colloids restore volume in a 1:1 ratio. Currently available colloids include human albumin, hydroxyethyl starch products that is mixed in either 0.9% isotonic sodium chloride solution or lactated Ringer's solution or hypertonic saline dextrin combinations. The sole product that is avoided routinely in large volume, that is more than 1500 milliliters per D restoration, is the hydroxyethyl starch product mixed in 0.9% isotonic sodium chloride solution, because it has been associated with the induction of coagulopathy. In patients with hemorrhagic shock, hypertonic saline has the theoretical benefit of increasing intravascular volume, which with only small amounts of fluid. The combination of dextrin and hypertonic saline may be beneficial in situations where infusion of large volumes of fluid may be harmful, such as in elderly persons with impaired cardiac activity. PRBCs should be transfused if the patient remains unstable after 2000 ml of crystalloid resuscitation. For acute situations, O negative non-cross-matched blood should be administered. Administer 2 units rapidly and note the response. For patients with active bleeding, several units of blood may be necessary. There are recognized risks associated with the transfusion of large quantities of PRBCs. As a result, other modalities are being investigated. One such modality is hemoglobin-based oxygen carriers. If at all possible, blood and crystalloid infusions should be delivered through a fluid warmer. A blood sample for type and cross should be drawn, preferably before blood transfusions are begun. Start type specific blood when available. Patients who require large amounts of transfusion inevitably will become coagulopathic. FFP generally is infused when the patient shows signs of coagulopathy, usually after 6 to 8 units of PRBCs. Platelets become depleted with large blood transfusions. Platelet transfusion is also recommended when a coagulopathy develops. And from today's topic, both shock and hemorrhage is important, and in that septic shock, SIRS, and the types of hemorrhage, types of shock, all these things are important questions, so please go through that again. Have a nice day. Thank you.